पर लॉयल्टी नहीं मिलती। तो तुम लोग तो वैसे ही अवेल कर लेते हो ना बीच में पंचन। 1 जून, 1 जून वो बेस्ट स्लॉट है, मतलब उसमें 2 दिन 16-17 की छुट्टी के मिल रहे एट स्ट्रेच। लेकिन मेरी एचओडी भी सेम टाइम। Okay. So basically, what we understand by this model is that the first stage is the pre-contemplation stage. Now, in the pre-contemplation stage, the person is not convinced about quitting tobacco. He does not believe that quitting will result in anything positive. Okay. So when patients come to us who are in the pre-contemplation phase, what they say is that we tell them that, okay, quitting will help in your oral health, and, by consuming it can lead to cancer. So they will be like, it's okay, so many people are taking it, so it doesn't really matter. So they are neither convinced that there will be any harmful effects, nor are they ready to quit. They feel that they have this one habit in life, like, some people, they don't want to quit tea. So they feel that we do not want to live without tobacco, and they are not convinced that it can lead to anything harmful as well. So that is the pre-contemplation stage. Okay. The second one is contemplation. Here, the person knows that it is harmful, but he is not committed to quit. So this case where the patient understands the harm of the tobacco and he is not willing to quit, that, or he's not convinced enough, the answer will be contemplation. Okay. Also, the next stage is preparation, where he's planning to bring about the changes in his life. He's planning that, okay, on this particular date, I'll be quitting, or maybe it is time that I should quit. So he's planning in that direction. That is the preparation stage. Action, where he has already, brought lesser amount of tobacco from the market. So where he's taken the action in order to start quitting, where he's stopped maybe the consumption of tobacco right after waking up. So according to Phlogiston test, we figured that, people have varying levels of addiction. So based on that, we will say that he's taken the action. Maintenance is that there is an ongoing practice of new healthier behavior, where he's maintaining the quitting part. Okay, so the answer in this case will be contemplation. Now coming to the second question, that is SMART in dentistry refers to. Okay, so basically we could not exactly recall what were the options in this case. So here the question is, we could only recall one answer, I believe. So what they said is that hand excavation of all the carious lesions and the SDF application. So any students, can anyone tell me if they can recall anything else in this? So I believe what I was told in this case is that, so I think this is the only, one moment. Is anyone aware of any other things, like any other questions being asked? Or any other options in this case? Okay, so I think let's just understand that what is smart dentistry. So if we understand the concepts, maybe we can go about that. So smart in dentistry means that basically smart is a technology where we are trying to save up, so this is something that in one visit itself, okay, the patient just goes to the dentist once. In one visit, they are trying to apply the caries is basically arrested. So we are arresting the occurrence of caries, and the patient is applied silver diamine fluoride as well as GIC. So the silver diamine fluoride has remineralizing properties as well as antibacterial properties. Okay. So the dentin is excavated. So the caries dentin is excavated, and GIC blocks the nutrients coming from the caries structure to the microorganisms. Okay. So this is the procedure where, however, in this case, with one visit, it does not suffice. So the patient has to come for multiple visits. Okay. So with this technique, but it is very in one visit itself. Normally, in the initial procedure with the SDF and the GIC, in one visit it is taken care of. But the patient has to keep coming and get it filled multiple times. Okay, so this is what we understand by the SDF. Okay, by the smart dentistry. Okay, so coming to the next question. SDF is not indicated in which of the following? That is pulpal involvement, silver diamine fluoride, right? It has remineralizing properties. So it will remineralize the dentin when the dentin is present. However, it is not useful if the pulp is involved. So here the answer will clearly be in case of pulpal involvement. Why? What are the indications and the contraindications of silver diamine fluoride? Okay. So silver diamine fluoride treatment is recommended when there is high caries risk. Okay. The patients who cannot tolerate surgical restorations due to age, behavior, basically people who cannot undergo surgical restorations, it will be used in those cases. People who have a large number of caries, okay, and those in whom they want to delay the use of sedation or anesthesia, okay. Also, it is indicated where more lesions that can be treated in one appointment, okay. Financial barriers, people who cannot afford more expensive treatment, who do not have proper access to care because one appointment, people who have salivary dysfunction, difficult to treat lesions, recurrent caries, carious primary teeth, which will soon exfoliate in them we will do because it requires multiple applications. So this will go for primary teeth, we can manage it for the time being. Carious lesions that are either asymptomatic or have reversible pulpitis or hypersensitivity. What are the contraindications? The contraindications is what was asked, if carious lesion extending to the pulp. So this is the answer. In case of irreversible pulpitis, it is of no use if people who have, because it incorporates silver. So people who have silver allergy, they are not used. In people with mouth sores and ulcerative gingivitis, in these people also, we do not use silver diamine fluoride. Okay. Coming to the next question. So, as per the hierarchy of evidence, which is the highest level of significance lies in which of these studies? Okay. So, there is a chart which is the hierarchy of evidence. So, when we believe that this particular study is done, that carries the most authentic literature. Okay. So, I'm very happy to tell that this was the query which was asked on the 16th May, and I had explained with this diagram in your query telegram group. So the same thing has come here. So basically, we will say that the clinical practice guidelines have the highest evidence, followed by meta-analysis. So which will be the answer in this case? Out of these options, case report, systematic review, cohort study, randomized control trial, the type of study with the highest analysis is meta-analysis, where all the studies are collected and an analysis is done, and the best literature or the most authentic literature is being produced. So that will be your meta-analysis, after which is randomized control trial, after which is your cohort studies, then comes your case control studies, then is your case report, and then is animal study. So out of all these, meta-analysis has the highest, okay. Meta-analysis will be higher. Okay, then will be your randomized control trial. So answer is definitely your meta-analysis, right? And after that is your cohort study, and then comes your case report study. Okay, so you understood this question? Okay, so when the validity of a test is compared with a gold standard test, it is called as. Okay. So now what do we understand by gold standard? Now, suppose you want to compare the efficacy of a mouthwash. Okay. Now, we want to compare a particular new mouthwash which has come in the market. Now, we will compare it with the mouthwash which is already established to be a good mouthwash. So what would that be? For example, whenever we compare a new mouthwash, we compare it with chlorhexidine because that is the gold standard. It has been certified that yields the best results, and it is proven to be a good mouthwash. So basically, validity, what do you mean by validity? Validity is that it is measuring, that particular test is measuring what it is actually intended to measure, what it is supposed to measure. Okay. So when the validity of a test is compared with that of a gold standard, it is called as a criteria. Okay. It is called as a criteria validity. Now, this query was also asked about validity by you all in the month of May itself in your Telegram group. This is a screenshot of that. So basically, I'll be again explaining these types of validities. So what we understand by criteria validity is that suppose you want to assess that how your exam system is basically useful in evaluating the further academic performance. So how do we compare that? We want to compare the college entrance exam and how effective it is in evaluating the academic performance. So we will compare it with the first semester, so which is the gold standard. Okay, that is the criteria, that whether it is valid or no. This is what we understand by that. Okay, so coming to the other option, which is your content validity. Okay, so content means that it should contain, okay, it should contain all the necessary information. Okay, for example, it should ask questions about the product, such as what are the features of the product, what is the quality of the product, what is the performance, what is the color design, and what is the price. Okay, that will be the content validity. Okay, so this is what we understand by the content validity. Coming to construct validity. Construct validity means that it actually represents the thing that we want to measure. Okay, for example, whatever we aim to measure, that is what it is representing. Okay, so for example, you want to build a questionnaire that measures depression. However, it is essential to know that your question is measuring the diagnosis of depression. It is essential to know that your questionnaire is not measuring the measure respondent's behavior, his level of happiness, or some other construct. It should measure what it is actually being constructed to measure, what it is being made to measure. Okay, so this is what we understand by the construct validity. Okay, coming to face validity, what do we understand? There's another type of validity which is not given in these options. Face validity is how it looks like. Okay, so basically how the research, like it is validity of the research based on how it looks. So this is basically the weakest and the least specific kind of a validity, that is your face validity. Okay, so this is one thing that one of the types of validities. What is convergent validity? So by convergent validity, we mean that degree to which two measures which are theoretically related, they should be like, two measures which should actually be theoretically related, the degree to which they are actually related. Okay, that will be your convergent validity. Okay, so this is what we understand. So here our answer for a gold standard, it is always criteria validity. Okay. Okay, so coming to the next question, this is the same exact question, the query of which was asked by you all. This is the screenshot of the query answered by me. So this is basically the same question which is being asked. When is the data set not according to Bell's distribution? Okay, so here it says when the range is 5 times SD, when range is more than interquartile range, when there are no outliners, and when mean is much lesser than the median. Okay, so this will be the answer. Okay, so basically, this is the exact question, which is a repeat question. So basically, Bell's distribution, okay, Bell's distribution or a normal curve, that is when mean is equal to median is equal to mode. Okay, this is what we understand by a Bell's curve. So anything which is not that will be a skewed diagram. Okay. For example, the right, okay, if the diagram is skewed towards the right side, which is this particular diagram. So in that case, if it is right-tailed, this is when mean is more than median and is more than mode. Okay, if it is skewed towards the left side, as it is in this case, so left tail, it is mean is less than median is less than mode. Okay, so basically we have to understand that mean for a normal curve or for a Bell's distribution, mean is equal to median is equal to mode. So the characteristics for our Bell's curve is this, okay? Here the mean, median and mode will coincide. Okay, the total area will be, the standard deviation in this case will be 1. Okay, so these are the characteristics of a normal curve. Okay, the mean will be 0 in this case. Okay, all the three findings will coincide. Okay, so coming to the next question, which is non-parametric test, which is equal to ANOVA. Okay, so ANOVA is basically a parametric test which measures 2-3 independent observations, and it compares the means. Okay, whereas Kruskal-Wallis is the answer. It is the non-parametric test and it compares 2 to 3 medians of a population. Okay, chi-square can't be because this incorporates the qualitative data. Okay, and it does not measure the quantitative data. And chi-square compares the proportions or compares the association. Okay, so these are the two important tables where the table 1 contains the independent groups. Okay, which is the 2 or 3 different groups, and table 2 has the paired groups or data. Okay, here we have one group, but we measure it 2 to 3 times. Here we have 2 to 3 independent groups. So here these are the two tests. Okay, so if there are two groups and if the distribution is normal, then and the data is quantitative, then you will take the t-test. If there are more than two groups and the data is quantitative, you will measure a one-way ANOVA. Okay, if the data is for example non-normal distribution, then you will have a Mann-Whitney U test. If the data is in this category more than two groups, okay, the data is quantitative Kruskal value ANOVA. Okay, if the data is categorical in nature, then what you will measure is chi-square or the Fisher test. Okay, if it is qualitative more than two groups, then again chi-square test. So for a categorical data, the option is chi-square test. However, in the second one, when there's a paired group, okay, so if the data is quantitative and the distribution is normal, so if there are two pairs of groups, the test will be paired t-test. Okay, if there are more than two repeated measures or ANOVA. Okay, so similarly for a qualitative data, we will have a McNever test or a Cochrane Q test. Okay, so this is one of the questions, and then the last question is, which of these is not a role of Anganwadi workers? So I think this was not completely recalled. I believe the option was 18 to 55, and some said the option was people. So people would be wrong because that will incorporate both male and female. Okay, if it is women and it is between 15 to 45, then it is can be the right option. Okay, it is of course child education from 3 to 6 years. It is immunization. Some said that immunization is not an option, so we do not know. And pre and post natal checkups. Okay, so of course, see, basically the function of Anganwadi workers has everything to do with the maternal and the child health. Okay, so Anganwadi workers take care of the maternal and the child health, also providing the nutrition and health education for women aged 15 to 45 years. Okay, only for the women, and nutrition and health education. So I'm not sure what was the option given here, but you should know that these are the services provided by the Anganwadi workers. What is that? Supplementary nutrition below 6 years of age for pregnant and lactating, that they should be well nourished, pregnant and lactating below 6 years of children. Immunization of children below 6 years for pregnant and lactating. Health checkup for children below 6 years, also for pregnant and lactating. Referral services for children below 6 years for pregnant and lactating. Basically, referral of these children, nutrition of these children, immunization, checkup, okay, the preschool education before the school, and nutrition and education for women for 15 to 45 years. Okay. So I'm not sure if any one of you have written any questions or there are any participants, I mean, any doubts or options, but so any questions or any inputs regarding the question? I think none. Okay, so um, I believe that's about it. That's about the PhD questions. I wish you all the very best for your results, and I'm hoping to see you on the other side and see you all as masters very soon. So, all the best.
Langerhans cell is a non-keratinocyte cell, right? So, this non-keratinocyte cell is mainly dendritic. It is an antigen-presenting cell. It is an antigen-presenting cell. Just like melanocyte, it is also clear cell and dendritic cell. It is mostly present in the uppermost layer. As it is an antigen-presenting cell, it will identify the antigen, engulf it, and it will present it to the T lymphocytes or lymph nodes. So, and what is its derivative? It is derived from hematopoietic origin, that is bone marrow. Now they are asking about G-specific granules. G-specific granules are not present in Langerhans cells. It has Birbeck granules, flask-shaped or tennis racket-shaped appearance. In this diagram, we can easily appreciate the flask-shaped nucleus. Nucleus is mainly convoluted, and this flask-shaped appearance is seen here in the cytoplasm. This is Langerhans cell having dendritic processes present in the uppermost layer. So this Langerhans cells is mainly convoluted nucleus with the presence of Birbeck granules. So remember this, Birbeck granules are mainly present in Langerhans cells, not the G granules. So the correct answer here is dendritic cells. Hence, because it has processes and it is an antigen presenting cell. As it is an antigen presenting cell, main function is of immunologic function. It has immunologic function. So it is present. Here we can easily appreciate in the supra-basal layer, not in the basal layer. Melanocytes are mainly present in the basal layer, while Langerhans cells are present in the supra-basal layer. And Birbeck granules, tennis racket or flask-shaped appearance. Now coming to our next question. Very easy question. Highest pigmentation is seen in. So highest pigmentation is seen in what? Palate, gingiva, tongue, or mucous membrane. Highest pigmentation. This pigmentation can be physiologic, it can be pathologic, it can be endogenous, it can be exogenous, right? It can be brown, it can be blue, it can be purple, it can be black. But most commonly, our physiologic pigmentation is most commonly seen in gingiva. It is most commonly seen in gingiva. It is present in mostly 1 to 2 decades of the life, but patient may appreciate it at an older age. So it is present where? It is present mostly on attached gingiva. It is bilateral, well demarcated, and covering in a caul-like fashion around the tooth. It spares the marginal gingiva. The pigmentation can also be seen on tongue, palate, buccal mucosa, right? They are but least differentiated, least demarcated. So this physiologic pigmentation is mainly seen on attached gingiva. It can be of which color? It can be of light to dark brown color. And in the rest of the portion, the pigmentation can be in patches. So the correct answer for this question is gingiva. So very few questions from DADH. One from oral mucous membrane and one from another from again an oral mucous membrane question. So we completed with our recall session for DADH. You can contact us on our Telegram group if you have any doubt regarding this. Thank you. Good night. Now, Dr. Anaya from Pedodontics will take over the session.
Hello, my dear students. A very good evening to you all. So this is the session for the discussion of your INI-CET Pedodontic section. So I went through the questions that we procured, and I think they were just direct picks from our lectures, from the lectures or the notes that we had made for the subject. There was no tricky clinical question, nothing, straight question out of the notes. So the first question was, yeah, what is the indication of the lingual arch appliance? So, my dear students, the lingual arch appliance looks something like this. So, it looks something like this. So, obviously, if it says lingual arch, that means 100% it is an appliance that is used for the mandibular region, not for the maxillary region. So that makes B and C obviously the not so correct options. They are definitely wrong. Then again, to prevent thumb sucking, there is no use of the lingual arch in preventing thumb sucking. The answer is where multiple mandibular the molars that are decaying need extraction. So the lingual arch appliance is basically a space maintainer. So it is a space maintainer for the for the mandibular arch, right? It has nothing to do with the maxillary arch, for the mandibular arch only, and it is not a habit breaking appliance, so not used for thumb sucking. All the habit breaking appliance, especially the ones that are used for thumb sucking, are the appliances that are put in the maxillary arch. Okay, so that makes B, C, D the wrong options and A is the correct option. Okay, then comes what is mesial step molar relation in a primary molar. So they had asked you what is the mesial step relation. So option A says distal surface of the upper and the lower secondary primary molars are in the same vertical plane. That means this distal surface is in the same vertical plane. So when I say same vertical plane, it becomes the flush terminal plane, right? Option B says distal surface of the lower second primary molar is more distal. So that means this. Okay, so this becomes when it is more distal, when the lower molar is more distal to the upper molar, that means it becomes a distal step terminal plane. Okay, then option C says the distal surface of the lower second primary molar is more mesial to the upper second primary molar. Okay, so the distal surface of the lower is more mesial. That means it becomes the mesial step terminal plane. Okay, so the option here is, the correct option here is C. That is when the distal surface of the lower second primary molar is more mesial to the upper second primary molar. So the answer is this. You just had to read the options one by one very patiently, make a diagram, in your mind, and the answer was right there. Nothing tricky in this question, right? Then we had another question that was how to diagnose the initial caries in ICDS, for that is ICDS score 1. So how do you diagnose ICDS score 1? The options that were given were first visual change by drying of the teeth, deep dentinal change, brown discoloration, or enamel breakdown. Okay, so the three, that is the deep dentinal change, brown discoloration, and enamel breakdown, all three of these options basically point towards an advanced caries, advanced stages of ICDAS. So they are definitely not ICDAS score 1. They are, the answer is undoubtedly first visual change by drying of the teeth. So what do you do? This ICDAS score 1 is also called as initial caries or white spot lesion. And what happens whenever the tooth is wet due to the refractive index, it is not visible. But if you dry the tooth, then you will see a clear white opaque patch on the on that particular tooth, which demonstrates an initial caries or the white spot. So by drying of the teeth, you are changing the refractive index, you are drying away the water, and hence that particular white opaque patch will be clear and visible to you, and that is going to demonstrate initial caries, that is ICDS score 1. So very quickly, score 0 is no change at all in the enamel. Score 1 is the first visual change that can be seen only after prolonged air drying or restricted to within the confines of pits and fissures, right? And then score 2 is distinct visual changes. Score 3 is the local enamel breakdown. Score 4 is the dark shadow, underlying dark shadow from the dentine. Score 5 is distinct cavity with visible dentine. And score 6 is extensive dentine cavity with visible dentine. So this is how goes the what do you call as the ICDS score, and our answer was score 1, that is the first visual change that is seen only by drying, prolonged drying of the tooth surface. That brings us to the fourth question. Thumb sucking habit is considered normal till what age? So basically, when you read it in theory, when you're reading it theoretically, so you will always read that thumb sucking habit is normal up till the age of 2 to 4 years. Okay, that is what you will read in the standard theory books. So when we say 2 to 4 years, that means we will always take the upper limit as the answer. So the answer here becomes 4 years. So the answer will be 4 years. Thumb sucking habit is considered normal up till the age of 4 years. Okay, that brings us to the fifth question. So fifth question, what they've asked, a procedure in which the exposed pulp is covered with a material to enhance reparative dentin formation over the pulp which is exposed by mechanical exposure is known as what? So mechanical exposure is generally a pinpoint exposure. They did not mention carious exposure. They mentioned a mechanical exposure, which is a pinpoint exposure. And they have put a material directly on the pulp to generate reparative dentin. Now, when you look at the options, option B says indirect pulp capping. Look at option B, which is indirect pulp capping. So because the question says you have covered the exposed pulp with a material, so that means you have put some material directly on the pulp. That means indirect pulp capping is not the answer. Okay, because for indirect pulp capping, you have to have dentin over the pulp. The pulp should not be exposed. So B is cancelled. Okay, now Civex pulpotomy and partial pulpotomy are the same thing. Partial pulpotomy is also known as Civex pulpotomy. And what is it? It is basically that the exposed part of the pulp or the inflamed pulp, some millimeters below the inflamed pulp is removed and some part of the coronal pulp is still retained, and over it you put some material and then you do the restoration. So since this becomes a similar procedure and you cannot mark both the answers, so the answer becomes direct pulp capping. That is because there is a mechanical exposure, so we understand it must be a pinpoint exposure, and there is material directly over the pulp, so it becomes direct pulp capping. They have not mentioned an inflamed excessive coronal pulp or an extensive procedure where they are supposed to remove the pulp, so it is not pulpotomy. Indirect pulp capping, the answer it cannot be because there is no dentin layer, the pulp is already exposed, so the answer becomes direct pulp capping. So that brings us to the last question of pedodontics. So basically the question that was asked was about incisal liability, and they had given 4 options. The question was incisal liability is compensated by all except what? So I will tell you what helps to compensate the incisal liability, and you had to choose which is the wrong option. Okay, so the incisal liability basically in the maxilla is around 7 mm and in the mandible is 5 mm. What is incisal liability? So the permanent incisors are larger as compared to the primary counterparts. Okay, primary counterparts are smaller, and thus they require greater space. The permanent teeth will require greater space to come in properly in the arch for their alignment. So therefore, the difference between the space, the less space that is available and the more space that is required, the difference there is called as incisor liability. Right? Now, how is the incisor liability compensated? So incisor liability is compensated basically by three situations. First is utilization of the physiological spaces. You all know there is generalized spacing in the primary dentition, which are known as the physiological spaces. So in the maxilla, there is around 4 mm of physiological spaces that is available, and in the mandible around 3 mm of physiological space is available. So by using this space, this space is one of the methods by which the incisor liability is compensated. The second is increase in the intercanine width. So the intercanine width increases with age. As the person transitions from the primary dentition to the permanent dentition, the intercanine width increases. So in the males, it will increase 6 mm in the maxilla and 4 mm in the mandible, and in the females it will increase 5.5 mm in the maxilla and 4 mm in the mandible. And the third way by which the incisal liability is compensated is by the change in the incisal angle. So there is an inclination between the two teeth, So the primary teeth are inclined at an angle of 150 degree, which is a greater angle, and the permanent teeth are inclined at an angle of 123 degree, which is a lesser angle. So when it is inclined at a lesser angle, they require lesser space. So by these three methods, the incisal liability gets compensated. So whatever option was there apart from these three methods was the correct answer, because they had asked you what type of how does it get compensated except. Okay, so except, that means you had to choose the wrong option amongst these. So apart from these three was the correct answer. Okay, so these were the questions for pedodontics, and these were really straight questions, really out of my lectures. There was nothing tricky, nothing twisted, no clinical questions. So I hope you've marked all the pedodontic questions correctly. So all the very, very best for your results. Good night.
So, very good evening. Can you all see me and hear me? So, very good evening to one and all present here. Okay. So, now you guys are done with your INI exam. You are done with your NEET PG exam. So, this is the time for you to slightly relax. ठीक है? अभी काउंसलिंग अभी आगे क्या करना है दैट वी विल सी दैट वी विल डिसाइड ओके बट अभी वी हैव टू स्लाइटली रिलैक्स बिकॉज इट इज वेरी इंपॉर्टेंट टू मेंटेन योर वर्क एंड योर पर्सनल लाइफ. Now, to be very honest, this recall is not for the students who have already given the paper. This recall is for the students who are at the middle of the preparation. Okay, so now you are done with your 10 to 12 subjects. So now you should be aware. So now you should be aware that what theory is important. So to know that what theory is important, it is very important to know the past year question. It is very important to know the past year question because this will tell you that in that theory what you have to revise again and again. Okay, so let's start with the with your INI recall of oral pathology. Okay, so the first question, which of these is the most common inheritance pattern seen in anhydrotic type of ectodermal dysplasia? Chalo, I believe that you don't know this anhydrotic type of ectodermal dysplasia. Okay, but which is the most common type of ectodermal dysplasia? It is anhydrotic type of ectodermal dysplasia. And what is the inheritance? We know that ectodermal dysplasia male is to female ratio. Male is to female ratio is 10:1. So the answer for this is S-linked recessive. Okay. So even if the X will get affected in the male will show the disease. So it is a X-linked recessive disorder. Okay. Now there are two types of ectodermal dysplasia. We have hypohydrotic, which is also called as anhydrotic. And the second one is hydrotic type of ectodermal dysplasia, which is called as Clauston syndrome. Now, how this is different from the anhydrotic type of ectodermal dysplasia? So we have hydrotic type of ectodermal dysplasia, which is called as Clauston. Now, this is autosomal dominant. Okay. Now, which is the most common? It is anhydrotic type of ectodermal dysplasia. It is most common. Now, Clauston syndrome. It is autosomal dominant. Now, what is different from anhydrotic? Here, the patient will have normal facial appearance. The patient will have normal sweat gland. Along with, very important feature is, there will be no dental anomaly. There will be no dental defects will be seen in this. Okay. So, this was a very direct question, and the answer for this question is X-linked recessive. Now, the syndrome associated with oral malignancy. They have particularly mentioned about the oral malignancy. Now, Peutz-Jeghers syndrome and Gardner syndrome, it is, yes, it shows malignancy, but what do we see here? Here we see intestinal polyps. While these intestinal polyps in Gardner syndrome, it has a 100% risk of malignancy, while in Peutz-Jeghers, it is 18%. Okay, but these are intestinal malignancy, not the oral malignancy. Coming to the Gorlin-Gall syndrome, many students, they have marked this as a Gorlin-Gall syndrome, considering it as a basal cell carcinoma syndrome. Now, basal cell carcinoma syndrome, tell me, basal cell carcinoma, it is a skin malignancy, okay? It is the most common skin malignancy. Basal cell carcinoma syndrome. So, what kind of carcinoma it is? It is a skin malignancy. While xeroderma, coming to the xeroderma pigmentosa, it is a disorder of DNA repair. Now, again, this is also it is most commonly, it develop into skin cancers, but in Schaefer, it is clearly written that squamous cell carcinoma is very common. So here the answer is xeroderma pigmentosa. Okay. Now here again, this was also very direct. We have seen this in our all life classes. In many recalls, we have seen the same question coming again and again. And even in the list of important topics, I have given you this topic. Okay. So image below show a matrix of mucoid and myxoid regions along with duct-like structure. Okay. So duct-like structure, where do we see? We see in the salivary glands. What is the diagnosis? Chalo, theek hai. Even if we don't know this histopath, then also we can mark this MCQ. Okay, so marking an MCQ, it is a complete art. Okay, so you just have to, for many questions, you just have to rule out the options. Okay, Wathin's tumor, it is also called as papillary cystadenoma lymphomatosum. Matlab, what will be present? There will be lymphocytes. Can you appreciate any kind of lymphocytes with epithelial or the papillary projection? No. Adenoid cystic carcinoma. So it is a malignancy. Now, for a malignant lesion, it has to be dysplastic cell. Any feature of malignancy can we appreciate? No. Okay. So the answer here is pleomorphic adenoma. Now, pleomorphic adenoma, by name, it is, we can say that there are many morphologies are seen. So what morphology do we see? Here we see epithelium in the form of duct or duct-like structure. Epithelium in form of duct-like structure, while the connective tissue, it is present as hyalinized, myxomatous, chondroid, myxomatous. Now, because of presence of this epithelium and the connective tissue, both the structures, they were considered it as a pseudo-mixed tumor. Pseudo-mixed tumor. But then later it was seen that even the epithelium and the connective tissue, they are derived from myoepithelial cell or ductal reserve cells. So what are these? What are these? These are progenitor cells. Progenitor cells. Let me just have a look. If you guys have any doubt, then please just let me know. Hi Sudhashri. Hi Prashant. Yes. So here the answer is pleomorphic adenoma. Okay. Now coming to our next question. So this is also a very direct question. We have seen this in our live session. Okay. So histology of a pathology in which there were spaces were seen with hyaline material, small or inconspicuous nuclei with perineural invasion. Okay. So now let's have a look on the options. So perineural invasion. Okay. So calcifying epithelial odontogenic tumor. Okay. CEOT. Yes, we see some kind of hyaline material. Okay. But we do not see any kind of perineural invasion in CEOT. Okay. Acinic cell carcinoma, adenomatoid odontogenic tumor. Now you have a confusion between adenoid cystic cell carcinoma and acinic cell carcinoma. Okay. Now perineural invasion, it is not seen in acinic cell carcinoma. Perineural invasion, it is also seen in polymorphous low grade adenocarcinoma. So it is seen in adenoid cystic cell carcinoma and polymorphous low grade adenocarcinoma. Okay. So since this option was not there, it was very easy to mark this answer. Okay. So the answer is adenoid cystic carcinoma. Now, what is this pattern? What they are trying to show in this histopathological feature? Now, to mark any histopathological diagram, you have to see exactly what they are trying to show you. Okay. So now, can you see this cystic spaces? Okay. So this image was discussed with you all in the class. Okay. So what is this? This is a Swiss cheese pattern. Swiss cheese pattern, which is seen in adenoid cystic carcinoma. Okay. So this Swiss cheese pattern, here we see cystic spaces, and this variant of adenoid cystic carcinoma, it is called as cribriform variant. Cribriform variant, which is the most common variant. So what other variants we have? Apart from cribriform, we have solid and tubular pattern. So which has the worst prognosis? Solid will have the worst prognosis. Okay. So I think with respect to oral pathology, the question they were slightly balanced. Okay, it was a balanced paper, right? Now, here again, this was a very easy question from the cyst. Okay, 6 to 9. Now you guys have to help me out with this question. 6 to 9 layer of epithelium, prominent stratum granulosum. Okay, prominent stratum granulosum, distinct cuboidal basal cells, and a palisading nuclei which are vertically oriented. Cystic spaces show what is the diagnosis. Now see, we know orthokeratinized OKC and parakeratinized OKC. Okay. Now, this is the histopath which I'm trying to show you. Okay. So we know that this is a orthokeratinized OKC because there is an excessive keratin which is present looking like a onion skin appearance. Now, if in your question they have mentioned prominent stratum granulosum. So prominent stratum granulosum we see in orthokeratinized OKC, and they have said that basal layer is cuboidal basal layer. Okay, cuboidal basal layer, cuboidal. It is not tall columnar cells. So as in general, OKC, what do we see? Tall columnar cells with palisading of the nucleus. Now again, this palisading of the nucleus, if it is a cuboidal cell, this palisading of the nucleus will not be seen in orthokeratinized OKC. So I think the options were slightly confusing if there is a presence of palisading nuclei or not. So can you guys just let me know that palisading nuclei was there in the option or not? Okay, because cuboidal basal cell with a prominent stratum granulosum. Can you see any prominent stratum granulosum here? No. We see tall columnar cells with palisading of the nucleus, giving it as a picket fence appearance or the row of tombstone appearance. Okay, this is picket fence appearance or row of tombstone appearance. Okay, so the answer, based on this information, the answer should go with orthokeratinized OKC. Okay, yeah. So now coming to our next question. This is a very easy direct question. Okay, we have been seeing this type of question since our UG days. Okay, so lesion below shows an atrophic epithelium with juxtaepithelial fibrosis of the connective tissue and homogeneous collagen deposition. Now, whenever the patient comes with this excessive collagen deposition, what do we say it as? Okay, that is oral submucous fibrosis. Now, what happens? The patient is not able to open the mouth properly because of extensive fibrosis of the connective tissue. So this excessive fibrosis of the connective tissue, when we see it histopathologically, we see juxtaepithelial band of connective tissue with fibrosis. Okay, so here the answer was very direct. It is oral submucous fibrosis. So you guys have any doubt? Patient also comes with excessive burning sensation in the mouth. Yes. So Pooja, you are talking about C. You are talking about which question? Is this question number 6? Kajal, will you please tell me? There was what? So I would like you guys to tell me about the question number 5. That is about the OKC. That was about the OKC. Okay. So now coming to our next question, that was from the dental caries, and I have given you the image of this question multiple times in the Telegram group, that this is very, very important. See, I do not know what was the option exactly, okay, but I know one thing based on this diagram. This is the translucent zone, okay, which is the innermost zone, okay, which is the innermost zone, and it is said that 50% of the time this zone is not present. Then we have dark zone. So this is the zone 1, this is the zone 1, this is the 2, 3 and 4. Okay, surface zone, very clear that it is present on the surface. Okay, now the dark zone, based on this table, it is given in your Schaefer, very, very important table. Okay, translucent zone, it is the first zone which we can see. It is the first recognizable zone of alteration. So half the lesion demonstrate translucent zone, but it is not always present. Now, pore volume, it is 1%. Now, sound tooth, that means the sound enamel, it has 0.1% of the pore volume because it has a sound hydroxyapatite crystals. So, whenever there is a dental caries, there will be formation of this pore volume. So at the translucent zone, the pore volume, it is 1%. It is 1%. Okay. Now, dark zone, it is present above the translucent zone, superficial to the translucent zone, and this is a positive zone. Most of the time, it is present. Okay. That is why it is called as positive zone, and the pore volume is 2 to 4%. So, whatever I am marking, that is important for you. Now, body of lesion, very important. See, body of lesion, this is the greatest zone of demineralization. Demineralization. It is the greatest area of demineralization. Maximum bacteria is present, okay? With pore volume 5% in periphery and 25% in center, okay? Now, coming to the surface zone, which is present at the surface, pore volume is less than 5%. So, based on this information, you had to mark your option, okay? Now, coming to this image, which is the last question, okay, of today's recall. The image shows with excessive keratinization. With excessive, so many students, they were slightly confused in this question, but I'll make it easier for you, okay? Let me just have a look. Palisaded nucleus was there, okay? Even if the palisading of the nucleus was there, and if they have mentioned that cuboidal cell, prominent, if they have particularly mentioned that there is a prominent stratum granulosum layer, that means they are pointing out towards the orthokeratinized OKC, okay? Huh. So this image shows excessive keratinization with excessive proliferation of epithelium in the connective tissue. Now, this image, based on this, I can see that there is an excessive keratinization with extensive proliferation of epithelium in the connective tissue. So this, I would predict it as a proliferative. They are talking about proliferative verrucous leukoplakia. Verrucous leukoplakia. Okay. Now, based on this information, for proliferative verrucous leukoplakia, based on recent article, 50% of the time it converts into malignancy. It converts into malignancy. But this is not a well-differentiated carcinoma. So this option is ruled out. It will result into malignancy. We are not aware. 100% risk of malignancy is not there. Okay. So we cannot say that it will completely result into malignancy. Definitely leads to malignancy and substantial develop into malignancy. So if you guys can help me out with the options, because these two options, they are very tricky, okay? Yes, if it is not treated, if not treated, then substantially, according to me, it will develop into malignancy, okay? So this was the recall with respect to oral pathology. Now I would suggest all the juniors that stick to your notes. Stick to your notes and solve past year questions. Yes, theory is important. Theory is important, but what in that theory, what you have to revise again and again, what you have to focus again and again, that you will get to know by knowing what are the past year questions, and these questions we have been doing in your theory, in your life lecture. So no questions, anything from here and there, okay? These all are the basic question and you all are well aware. So now you have recall of oral medicine by Dr. Priyanka ma'am, okay? So I wish you all the best, and please do tell me your rank so that we can go out and have party, okay? Chalo, bye everyone.
Hi, good evening all. Welcome to recall session of OMR. All right. So if I talk about OMR, the paper was moderate. All right. And if I'm recalling 9 questions, 6 questions were you would have attempted. Okay. And 3 questions were miscellaneous, means difficult, I would say. So let us start with the questions. All right. So this is first question. They had given this CT image, okay, and they had given this CT image shown below depict a condition due to elongated styloid bone. All right. Even if you are not able to judge what structure is that or what condition they had mentioned, but they have clearly written in the like question that the condition is due to elongated styloid bone. Okay, immediately you should have clicked the condition where we see elongated styloid process, right? What is that condition? It is Eagle syndrome, right? Eagle syndrome. And not just the condition they are asking what pathology is associated with this condition. All right, what pathology is associated with this condition. And they are given the options. The options were all related to neuralgia. So, neuralgic pain they had mentioned. And to answer this question, first you should know what happens in Eagle syndrome, what symptoms patients give, right? So, due to elongated styloid process, what exactly happens is patient will have a pain during swallowing. So, patient will have this vague pain during swallowing due to this elongated styloid process. And when patient turns or rotate their head, okay, that time also patient will have pain. Okay, so vague pain during swallowing, and when patient rotates their head. All right. Any options, addition of any option, subtraction of any option, you can suggest in the comment or in the chat. All right. Okay. Okay. So this it's the Eagle syndrome. The condition is Eagle syndrome. Now, what complication or you can say pathology is associated with Eagle syndrome? So if you pull out the options, so option C and D you can easily rule out. Say post-herpetic neuralgia is a complication of herpes zoster infection, right? Patient will have this burning continuous pain after the lesion has subsided in the post-herpetic neuralgia. All right. So it is basically a complication of herpes zoster. Complication of herpes zoster. Right? Option D was trigeminal neuralgia. Okay, trigeminal neuralgia, we all know. Patient will have electric shock like pain, and the attacks of this electric shock like pain, and between two attacks, patient will be completely normal. There are no symptoms seen in this period, right? So, trigeminal neuralgia is also ruled out. Now, meaning is glossopharyngeal and otic neuralgia. So, elongated styloid process, yeah, we can consider this proximity of ear, okay, or glossopharyngeal neuralgia. But what is the correct answer here? Okay, option A. Glossopharyngeal neuralgia is correct option, right? Why? Because in glossopharyngeal neuralgia, what happens is when patient swallows, when patient tries to speak, when patient say yawn, all right, when patient coughing, okay, that time what happens is there is impingement or compression of this glossopharyngeal nerve. Okay, what happens is impingement of glossopharyngeal nerve, right? And that will lead to this neuralgic pain where the distribution of glossopharyngeal nerve is like the areas of distribution of glossopharyngeal nerve will have these neuralgic pain, right? So during swallowing, this occurs. So it is not like the pathology associated with this condition, but these two conditions are very similar. So we can get confused, or you can give differential diagnosis when this elongated styloid process is seen, or when you can say uh, listen to the symptoms patient is getting during swallowing. He has this neuralgic pain. So glossopharyngeal neuralgia can be a diagnosis. And what is the differential diagnosis? Second differential diagnosis is you can suspect this Eagle syndrome. Okay, so you can advise radiographs. Okay, CT examination or OPG also can give you this elongated styloid process thing. All right. So this is about first question. All right. Any changes, any suggestions, or any you can say, you can write down answers in the chat box. All right. What you have marked in the exam. All right. All right. Moving on to the second question. So fresh film test will show. Okay, fresh film test will show option A dark film, option B white film, option C light film, option D clear film. All right. Now, to answer this question, you should know what is fresh film test. Okay. Now, fresh film test, what you do is you take fresh film from the fresh packet. All right, which is stored very perfectly. Okay, in ideal conditions. All right, and then you process it. You process the unexposed film. Okay, and what you see, they have asked here. Okay, either you see dark film, either you see white film, either you see light or clear film. So now, when you take out the unexposed film out of the fresh film packet, right? So it has this cloudy, you can say, unexposed film, right? Without processing. Okay, I'm talking about without processing here. Right, without processing you will be able to see this cloudy blue tint. So cloudy blue tint you will be able to see. All right, now what we have to do here is we have to process this unexposed film. Okay, so after processing, what you see is clear film, right? Clear film with blue tint. Clear with blue tint. Now, what is this blue tint? So, if you remember about the composition of film, we had studied, right? We have the base, and above which we have the emulsion, right? Emulsion layer. And emulsion is coated with a super coat, or you can say protective layer. Super coat, right? So this base which we have, it gives us blue tint. So whenever you look at the film, we'll see some bluish tint on the film. That is due to base. Okay, so here we are talking about fresh film test. So in fresh film test, what we do is we process unexposed film, all right, which will give us clear film. Okay, clear with bluish tint is the exact answer. But here they have mentioned clear film, so you can mark option D as the correct answer. All right. Any suggestions? Any options? We have written wrong. You can post it in the comments. All right. Okay. Moving on to the third question. Okay. Palatal papillary hyperplasia is seen in. Palatal papillary hyperplasia is seen in. Okay. Now, why I keep telling you in the classes, or you can say every time, that you should know synonym of the conditions. You should know synonyms of the condition, and that helps us to rule out the options. All right, so here also we have the option as Hex disease, option B focal epithelial hyperplasia, option C Epulis fish rat, option D candidiasis. Now here the question is little tricky. Option A and B are synonym of each other. Option A and B are synonym of each other. And in Hex disease, what we see is a sessile soft, okay, papules. Okay, sessile soft papules I'll just show you the image. Yeah. Here, if you see, okay, here we have papules, okay? They are sessile and the color of the papules resembles the normal surrounding mucosa, all right? And they are sessile and soft to touch, all right? This is Hex disease, and this is also called as focal epithelial hyperplasia, right? Now, we are left with option C and D, right? Option C and D. Now, Epulis fissuratum is basically your uh, uh, Epulis. Epulis meaning, I've told you what is the definition of Epulis, right? Epulis meaning any growth over gingiva, any growth over gingiva or alveolar mucosa, right? Alveolar mucosa. So when here we are talking about palatal papillary hyperplasia, you can directly rule out this if you know what is epulis, right? And epulis fissuratum is basically seen in association with dentures, okay? Denture wearing patient. The flanges, okay? Denture flange will cause this fibrous hyperplasia, okay? And that is not our correct answer here, okay? Coming on to the option D, now we have seen this classification in our classes, that this is the classification given by Greenberg and Glick in 2003. All right. And they have directly classified this papillary hyperplasia of palate in the hypertrophic or hyperplastic form of candidiasis. Okay. This is particular classification. This is given by Greenberg and Glick. All right. So, and what how the candidiasis answer here, when you talk about denture wearing patient, okay, we have seen that when patient does not maintain the oral hygiene properly, okay, and patient wears the denture 24/7, okay, they'll not remove it, wash it and anything like that. Under the denture surface there is a you can say growth of candida albicans, okay, growth of candida albicans, and that gives rise to palatal papillary hyperplasia that you can see over here, okay. This is palatal papillary hyperplasia seen, and this are seen as tightly, you can say, packed projections, right? Tightly packed projections, and on head palate this is seen. Okay. So what should be your answer here? Palatal papillary hyperplasia seen in option D, candidiasis. Okay, candidiasis. Little tricky question, but if you have studied properly, if you have studied the classification properly, you would have answered, right? All right. Question 4. Which of these infections is seen in HIV? Okay, and I keep showing you this classification in our classes, right? This is revised classification by European Community Clearing House in 1992. All right. So in this classification, they have classified the HIV lesions in strongly associated HIV infection, less commonly associated HIV infections, and lesions seen in HIV infection. I keep telling you, you remember the strongly associated HIV infections, right? If you remember this, you would have answered this question easily, even if you don't know the other options, right? Now, they have given this weird term like a gnathostomiasis, right? So this is nothing but a parasitic infection, right? Parasitic infection. All right. And this is a foodborne zoonotic disease. Okay. And it is not related to HIV at all. Okay. So this option is ruled out, right? If you look at the table here, classification here, lesions less commonly associated with HIV infection, we have herpes simplex virus infection and varicella zoster infection here. So they are less commonly associated with HIV, right? What we are remaining with? Option A, which is EBV, Epstein-Barr virus, right? Epstein-Barr virus infection. So they had not directly given the lesion associated with HIV, but they have given the virus, right? So if you look at the strongly associated lesions. We have candidiasis at first place, then we have hairy leukoplakia, then we have Kaposi, non-Hodgkin's, periodontal disease, right? When you concentrate on hairy leukoplakia is caused by what virus? EBV virus. EBV virus, Epstein-Barr virus. We have studied this under the viral lesions, right? So Epstein-Barr virus causes this hairy leukoplakia, and our answer here is EBV, option A. All right, everybody? Options are correct till here, or some changes? All right. Moving on further, see, we have this fifth question, and I would tell you one, like 2025 aspirants. I will tell you one, you can say, what you have to focus during studies. Okay. In this question, we are taking lesson from this question. Okay. Let's go. So, 10 years boy comes from multiple carious teeth. Okay, and image is given, obviously OPG was given, and he is treated for Hodgkin's lymphoma. He's treated for Hodgkin's lymphoma at 2 years of age. Okay, so they are given this. He has suffered from Hodgkin's lymphoma, and he has come in contact with, or he has undergone this therapeutic radiation or radiotherapy and chemotherapy, right? And what is the effect seen on the roots of permanent teeth? What is the effect seen on the roots of permanent teeth? All right, and the options were given as fusion, gemination, stunting, and compresence. All right, so we have taken this OPG. We don't know that it is a proper or not, but yeah. But according to the question, okay, according to the question, what should be answered here is, I will tell you one like trick, right? See, this I have directly taken this screenshot from the standard textbook. Okay, and if you look at the caption written under the image, all right, you will directly, like, you will be surprised that they have directly taken this caption as a question. Okay, little modification, but directly taken caption. So here they have given the dental anomaly after radiotherapy in two patients. Okay, first patient was 9 years old girl who received this 35 gray at age of 4 because of Hodgkin's lymphoma or disease, and had severe stunting of incisor roots with premature closure of apices at 8 years, right? At 8 years, right? And second patient was 10 years old boy who received 41 gray at 4 years of age, severely stunted root development of all permanent teeth with normal primary molars, right? So here you can see these roots. Roots are not properly developed. There is stunted growth of the roots, right? So the patient who have taken radiotherapy, we have studied about these complications after radiotherapy. The radiation affects salivary gland, due to which the saliva, the secretion of saliva decreases, due to which there are effects on teeth, radiation carries, okay, osteoradionecrosis. Okay, now teeth. Effects on teeth are these. Okay, so what do you see when the patient or the child is exposed to radiation, okay, for radiotherapy? And say, one option was hepatitis B. Okay, hepatitis B in the question, but EBV virus still remains our answer, right? EBV virus remains our answer here. Okay, Prashant, Prashant. Okay, now here we have two important points to note down. See, if the exposure occurs, okay, if the exposure precedes, calcification, okay, what happens is it will lead to destruction of whole tooth bone. Destruction of tooth bone. All right. Now, second condition is when the exposure occurs after calcification. After calcification of the teeth, right? Of teeth. What happens is it inhibits cellular differentiation. It inhibits cellular differentiation. All right. It inhibits cellular differentiation. And what will it cause? It causes malformation. Okay. Malformation in the roots. Malformed. Okay. Root. It will retard. It will retard or abort the root formation. So you will see such kind of condition, right? It will retard root formation. So you will see this dwarf roots, right? Dwarf roots or stunted growth of the root. So one of our option was stunting, right? One of our option was stunting, right? So when the patient undergoes this radiation therapy, this changes can take place, depends on whether it is before calcification or after calcification, but the eruption pattern, the eruption mechanism still remains same. Okay, eruption pattern is radio resistant. It does not affect the eruption pattern. Even if there is no rootless tooth, it will erupt into oral cavity. All right. Okay. So what is our answer here? So sorry. Yeah. Option C, stunting is the correct answer. All right. Stunting is the correct answer. Moving on further, question 6. If the coronal pulp chamber is long and wide, what it is called? Okay. Now we have discussed this in Power GT3. Okay. If these are the options, okay, option C and D we cannot not recall. Okay. But if you remember, please let me know. Okay. So based on this, what here I have um, we have answer here. If the coronal pulp chamber is long and wide, what is it? Okay, so we have discussed this question in Power GT3, right? Power GT3, thistle tip appearance of pulp chamber is a feature of, right? So it is like this. So long and wide pulp chamber. Please help me out if you can recall these options for this question. Okay, yeah. So if the coronal pulp chamber is long and wide, so I had discussed about dentin dysplasia. Dentin dysplasia, and we have two types in dentin dysplasia. First type was radicular, and second type was coronal, right? Radicular dentin dysplasia, roots are affected. Coronal, crowns are affected. Crowns meaning pulp is also affected, right? Radicular में what you will see is rootless teeth. Roots will be short or blunt. Coronal में क्या होता है? Pulp obliteration. You will see pulp obliteration. All right. In primary tooth and in permanent tooth, what happens is there is thistle tube appearance. Okay, thistle tube appearance. Thistle tube appearance you'll see. Okay. So pulp will become long and wide. Okay. Pulp chamber. So what answer we have here is option A, thistle pulp chamber. All right. Okay. Yeah. moving on to the next question. Yeah, this question is little miscellaneous. We are not like listened to it or studied this or discussed it. Okay, this is miscellaneous. So salmon patch pigmentation is a form of, okay, salmon patch pigmentation. But if you look at the options, and if you can just recall about the pigmentation, oral pigmentation chapter, in that we have discussed about vascular malformation, right? Vascular malformation, right? So little, you can say, if you would have answered based on this pigmentation, then you would have been correct. Okay, so salmon patch pigmentation is a form of, this is option D, vascular malformation. Okay, now in vascular malformation, what you see is this irregular, and it is mostly seen in the newborn baby. Okay, and this irregular dull patch, okay, pinkish red macular area that you can see, is what we call it as a salmon patch. Okay, and this comes under vascular malformation. Okay, vascular malformation. All right, so this is the answer for option, question 7. Yeah, moving on further, question 8. Parallax and sharpness of image is given. Option A, reduced exposure time. Option B, paralleling technique. Option C, high speed film. Option D, double emulsion. Okay. And when we talk about unsharpness, and when we look at the options here, these two options you can easily rule out, right? Reduced exposure time has no connection with unsharpness of the image. Paralleling technique, no. We get sharper image with the paralleling technique, so no connection with that. Then comes our high speed film and double emulsion. So high speed film, yeah, contributes to unsharpness, because in high speed films, the grain size, the silver halide size, crystal size is greater. Silver halide crystal size is greater, right? Great. But it can lead to unsharpness, right? But what I have mentioned here is parallax unsharpness. So parallax unsharpness is seen in double emulsion film. Double emulsion films. So there are types of films we have. So here, if we have this film, double emulsion layer means you have the emulsion layer on both the sides of film. Okay, both the sides of film. What happens when we expose this? When we expose this film, okay, what happens is, this is a tooth, right? What happens is, this, you do double emulsion, and you can say here, this layer will also be a film, right? This layer will also be a film. So source to film distance. Okay, if we talk about source to film distance is increased when we talk about this emulsion layer, right? This emulsion layer, source to film distance is increased, and due to which magnification happens. Okay, greater magnification happens. Okay, and unsharpness is more. Okay, so if this is a tooth, on film, what you can see is little unsharpness around this tooth. Little unsharpness, or penumbra, we call it as penumbra. So unsharpness is greater with the use double emulsion film. So what happens is, this layer has a decreased distance, right, as compared to this layer. So this layer has decreased distance or less distance than this layer. Okay, so this layer will show some magnification, and that lead to this unsharpness around the image, all right, and that is called as parallax unsharpness, okay, and that occurs due to double emulsion film, all right. Moving on to the ninth question. Okay, this question I want you people should help me. Okay, because some people have got different options, some people have got different options. So if you can just recall the options here. Okay, spiral nasal sinuses are best viewed by option A, reverse downs, option B, Waters view, option C, Carvel, or option D, Granger view. Granger view. Okay, if you can just recall whether these options are correct or not. Anybody? All right. So, considering these are the options we have here is in sciences. There are two views. Paranasal sinuses. Towns view were there. Okay, Towns view was there. Okay. So, yeah, paranasal sinuses, we have options here which gives us the view of paranasal sinuses. And there is one more option which is specifically or ideally done for the maxillary sinus. The maxillary sinus, right? All right. But we talk about these two options. What should be the correct answer here? Paranasal sinuses are best viewed in Carvel view. Carvel view. Granger view is C. Yeah. Yeah. So this we have discussed in our lectures, right? Granger view. Okay. This Carvel view is just a modification of the Granger view. Okay, we had just moving we just moved this X-ray source just about 3 centimeters of occlusal protuberance, right? And it should be 23 degrees to the cantomeatal line. Okay, it should be 23 degrees to the cantomeatal line. And in Vanguard, this X-ray beam, the central beam is perpendicular to the film. Okay, but in Carvel view, what we do is we just move this X-ray source to get better view. Now, what is the significance of the Carvel view? So it prevents this superimposition. Okay, prevents this superimposition. What happens in Granger view? It prevents the superimposition by just changing the X-ray source. Okay, the position of X-ray source. So Carvel view, here I have just put up this picture of Carvel view, right? Or you will be able to see frontal sinuses, right? Frontal sinuses, ethmoidal sinuses, and maxillary sinuses, right? Okay. So this Carvel view is best for paranasal sinuses. Okay. Due to some drawbacks were seen with the Granger view, they have modified this Granger view into this Carvel view. Okay. And yeah. So what do we call it as a PA, posterior-anterior view, right? Posterior-anterior view or occipitofrontal projection. It is also called as occipitofrontal projection. All right, PA view or occipitofrontal projection. And we have Granger here and Carvel view here, right? Carvel is just a modified Granger projection. All right, and this is best to view paranasal sinuses. Waters view best for maxillary sinuses, we all know that. Reverse downs is for condylar neck, high condylar neck, right? So these are the questions, recall question, okay? If you have any doubt, you can ask me in the comments. All right. Otherwise, we can conclude the session. And next session will be continued by Dr. Rajesh, sir.
Okay, so a very good evening, everyone. Yeah, so please let me know, am I audible and visible to all of you? Just give me a quick thumbs up, like if I'm audible to all of you. Yes, so am I audible to everyone? All right, okay. So now let us just go ahead with the general medicine questions. So I am myself Dr. Rajesh Guba. So I'll be discussing the general medicine questions of the INI-CET. So majority of them, like one was from the cardiology, one is from the ECG. So that is one unexpected question, because usually the ECG related questions have not been asked for you previously. And that too, like they have asked you the questions related to the ST segment elevation. Okay. So let me just show you the first question. Right. So this was your one of the question in the INI-CET, right? So ST segment elevation in leads V2 to V4 signifies myocardial infarction in which particular region? One second. Yeah. ST segment elevation seen in V2 to V4 leads signifies myocardial infarction in which particular region? So this was one of the question that you had, right? So anyone want to make a guess, and what did you answer in your exam? Right. So let me just quickly make out this. So V2 to V4, they are considered as the anterior leads. So they pick up the electrical activity from the anterior wall of the heart. And if there is the ST segment elevation in V2 to V4, that is suggestive of the anterior wall MI, right? Now, what about the other wall related MI? If it is lateral wall MI, the ST segment elevation will be there in lead 1, AVL, V5, and as well as V6. Okay. Now, if it is the inferior wall MI, then the ST segment elevation will be there in lead 2, lead 3, and as well as the AVF, right? So this will be the inferior wall MI ECG changes. Then followed by that, right? Then followed by that, what will be the ECG changes in the posterior wall MI? So if you take the ECG changes in the posterior wall MI, usually the posterior wall MI, it is associated with the inferior wall MI. Now, why is that? Why the posterior wall MI is associated with the inferior wall MI? Why? Because both of these walls, the posterior wall and as well as the inferior wall, they are supplied by the right coronary artery. So if there is block in the right coronary artery, then the individual can develop inferior wall MI or even posterior wall MI, depending upon where exactly the vessel is being blocked. So if the posterior wall MI is there, what will be the ECG changes? So one thing is you will have the inferior wall MI changes. What will be that inferior wall MI changes? That will be in 2-3 AVF, you will have the ST segment elevation, right? And along with that, what will be the specific features of the posterior wall MI? The specific features of the posterior wall MI is that you will have the ST segment depression. That means along with the inferior wall MI changes, you will have ST segment depression in lead V1 to V3, right? And what will happen to the R by S ratio? R by S ratio from V1 to V3, that will be more than 1, right? R by S ratio in from V1 to V3, it will be more than 1. So that will be the posterior wall MI changes. So if it is V2 to V4, it is suggestive of the anterior wall, right? And if there is ST segment elevation in V2 to V4, that is suggestive of the anterior wall MI. that is suggestive of anterior wall MI. Okay, so this was the question related to the ST segment elevation. And please remember, there are multiple other differential diagnoses for ST segment elevation. It is not just only in case of MI you will have the ST segment elevation. You have that in case of vasospastic angina, which is also called variant angina. You will also have ST segment elevation in electrolyte abnormalities like hyperkalemia. You will also have ST segment elevation in bundle branch blocks like left bundle branch block. You will have ST segment elevation. You also have ST segment elevation in case of the pericarditis, in acute pericarditis, not in constrictive pericarditis. Acute pericarditis, you will have the ST segment elevation. And the other condition where you can have the ST segment elevation is one of the sodium channelopathy, that is Brugada syndrome. There also you will have the ST segment elevation, right? Or if there is any pericardial injury secondary to pericardiocentesis, there also you will have ST segment elevation. So these are multiple other conditions where you will have ST segment elevation apart from MI, right? And yeah, we will move on to the next question. Right. So this was the emergency cardiopulmonary resuscitation compression to ventilation ratio in adult ease. Okay, but before going on to this question, I'll just show you the ST segment elevation. Yeah, so let me just show you the ECG of ST segment elevation from V2 to V4. So you can see this. This is what is your ST segment elevation from V2 to V4, right? And what is this suggestive of? This is what is suggestive of the anterior wall MI, right? And what is a vessel that will be blocked in anterior wall MI? It is the left anterior descending artery, which will be blocked in patients with the anterior wall MI. Okay. So if you have any questions related to this ST segment elevation, you can just ask me. I will answer your doubts. Right. Once we are done with the first question related to the ST segment elevation, now we'll move on to the next one. In cardiopulmonary resuscitation compression, compression to ventilation ratio in adult ease, right? Compression to ventilation ratio in adult ease, 60:1, then 60:2, then 30:2, 15:2. Yes. So what do you think is the correct answer here? Right. So the correct answer here is 30:2. So that means when you give 30 compressions, right? When you give 30 compressions, okay, you need to give 2 ventilatory puffs, right? 2 ventilatory puffs. Okay. That means with the bag and mask, you need to give 2 puffs, right? So that is, and this cardiopulmonary resuscitation, when is that you will be doing 15:2? When is that you will be doing 15:2? That is depending upon the age of the individual. Like for suppose, right, you see this table in adults, right? In adults, whether a single person is there or 2 rescuers are there, then it is same 30:2, right? That is compression to ventilation ratio. It is 30:2. But you take in case of children, you take in case of the children. In case of children, when 2 rescuers are there, right, 2 people are resuscitating, then in such case, like it is 15:2. Whether, and again, even in children also, for suppose if there is only single person who is doing the CPR, then it is 30:2 once again, right? So this is about the cardiopulmonary resuscitation. Now, followed by the cardiopulmonary resuscitation, what is the next important question that you had? Right. Now, yeah, this was another question related to endocrinology, right? So please tell me, was the question the same or was there any difference in the question? Which of these is most commonly associated with the hyperglycemia? Addison's disease, diabetes insipidus, Cushing's disease, Albright's disease. Yes. Was the question same, and was there any difference? And if so, like what do you think is the correct answer? Most commonly associated with the hyperglycemia. Right. Now we'll just take one by one option. What exactly is your Addison's? Addison's, it is a disorder which is characterized by the adrenocortical compression. Right? Addison's, it is a disorder which is characterized by the adrenocortical compression. That means you have decrease in the steroids in case of the Addison's. Once there is decrease in steroids, please remember the hepatic gluconeogenesis does not occur, and that will make the individual to develop the hypoglycemia. Right? That will make the individual to develop hypoglycemia. So in patients with Addison's, what is that you will have is hypoglycemia, but not the hyperglycemia. All right. Then you take the diabetes insipidus. In case of diabetes insipidus, you don't have much change in the glucose levels because the diabetes insipidus, it is a disorder which is characterized by deficiency of antidiuretic hormone or resistance to the action of the antidiuretic hormone. So that is the reason why in diabetes insipidus, you don't have much variation in the glucose levels, right? But the symptomatology is similar to that of your diabetes insipid, diabetes mellitus. Diabetes insipidus also, they'll have polyuria, polydipsia. And diabetes mellitus also, where there is hyperglycemia, you will have polyuria, polydipsia. But the glucose variation will not be there in diabetes insipidus. It is mainly the variation related to the osmolality, right? In diabetes insipidus, the serum osmolality increases and the urine osmolality decreases and serum sodium increases. Right, the serum sodium increases. That is what you will observe in case of the diabetes insipidus. Right. Now, coming to the Cushing's disease. Right, coming to the Cushing's disease. So what is the correct answer? The correct answer is the Cushing's disease. Correct answer is Cushing's disease. In Cushing's disease, thyrotoxicosis was one of the option, Nitika. If thyrotoxicosis was one of the option, because then even thyrotoxicosis also there will be hyperglycemia. And in such case, Cushing's and thyrotoxicosis both should not be the options then. Just recollect properly. And what about the other students? What do you say? Right. Now, you take the Cushing's disease. In Cushing's disease, it is a disorder which is characterized by increase in the steroid levels, right? So once there is increase in the steroid levels, what will happen? There will be increase in the hepatic gluconeogenesis, right? There will be increase in hepatic gluconeogenesis. Okay. So once there is increase in hepatic gluconeogenesis, that will cause the hyperglycemia. That will cause the hyperglycemia. So Cushing's disease is the one where you will have hyperglycemia. Now, what about this Albright's? Actually, Albright's is like Albright's hereditary osteodystrophy, right? Albright's hereditary osteodystrophy. And in patients with Albright's hereditary osteodystrophy, what is that you will have is you will have pseudo hypoparathyroidism. Right, you will have what is called pseudo hypoparathyroidism. That is what you will observe in case of the Albright's hereditary osteodystrophy, right? And in patients with this pseudo hypoparathyroidism, what you will have is the calcium levels, the hypocalcemia will be there, but parathormone levels, if you observe, either they are normal or in fact it is increased. That is what you will observe in case of the Albright's disease. Right? But you don't have any variation related to glucose in case of the Albright's disease. Okay. So the correct answer here is the Cushing's disease, where you have the presence of the hyperglycemia. Right? So this was one of the question related to the endocrinology. Right. And yeah, so this was the question. I did not get the options correctly. Right? Because this, like, only two options I got. Potassium deficiency is seen in. Potassium deficiency is seen in. That is what is the question that I have got. And hyperuricemia and hyperlipidemia. But surprisingly, the options what you have given to me, right? In both of these scenarios, potassium deficiency will not be there. In both of these scenarios, potassium deficiency will not be there. Neither in hyperuricemia nor in case of the hyperlipidemia. Right? So can anyone recollect the other two options? What was there? Yes, anyone? Please recollect the other two options, wherein we will try to make out like in which other option you have this potassium deficiency. Okay, I'll be waiting for your, the messages in the inbox. And when do we use this word potassium deficiency? The normal potassium levels are 3.5 to 5 milliequivalents per liter, right? And if the value of the potassium has been dropped to less than 3.5 milliequivalents per liter, then that is a point when we use the word hypokalemia. That is a point when we use the word hypokalemia, right? And hypokalemia is very dangerous. This hypokalemia, it is associated with tachyarrhythmias, and these tachyarrhythmias can make the individual to have a sudden cardiac death. And what are the types of tachyarrhythmias? VT and as well as VF. These are the tachyarrhythmias which are associated with hypokalemia. So that is the reason why you need to give KCl. Potassium chloride should be given, right? Yes, anyone? I did not get the messages until now. What are the other two options which have been given? What are the other two options? Potassium deficiency is seen in. Okay, so you please recollect and let me know, because no one is answering the other options. All right, then we will move on to the next question. Right. Yeah. So this was the another question. E-cigarette. It contains the nicotine content. E-cigarette contains the nicotine equivalent to how many cigarettes? So this is one of the standard question. So it is the option B. Option B. So e-cigarette contains the nicotine equivalent to almost 20 cigarettes. Right. And this was the another question. How do you confirm the CSF leak? One is by MRI, the other one is the halo test, and the other one is tau protein and then persistent rhinorrhea. So please remember, this persistent rhinorrhea will just tell you that there is rhinorrhea, but it will not confirm that it is definitely CSF leak. So how is that you will be able to confirm is that is by the tau protein. That is by tau protein. Okay, right. So these are, yes. So this is what, sorry, I'm sorry. I'm very sorry. Right. So how do you confirm the CSF leak is by the halo test, right? So halo test is the one which will confirm the CSF leak, right? So with this, we are done with the questions related to the general medicine, right? So if you are able to recall few more questions related to the general medicine, right? So you can just definitely text us on the Telegram channels, right? And you can just reach us and definitely know what are the remaining questions which are there related to general medicine. We are there here to help you, right? So with this, I will wind up this particular session, which is related to the recall of the general medicine, right? So any other queries or any other doubts, you can just let me know. I'll be waiting for some time. All right. So if you don't have any questions, then I wish you all the best for your result, right? So we will be waiting for your result. So we are also very much enthusiastic as you are for your result. So once you get the result, please just text us. We will be very happy, right? We will be very happy for looking your results. Thank you very much. Right. And so the next faculty who will be taking up the recall will be Dr. Pawan sir. So Dr. Pawan sir will be joining you for the recall of his questions, right? So thank you very much.
मनीषा, मैं दिखाई दे रहा हूँ?
Good evening, sir. Yes, sir.
मुझे शेयर स्क्रीन का ऑप्शन दे।
Given, sir.
कैसे करना है? मैं फोन पे हूँ। शेयर स्क्रीन, शेयर माइक्रोसॉफ्ट इमेज फ्रॉम शेयर डॉक्यूमेंट। ठीक है, मैं नजर आ रहा हूँ?
No, sir.
अब
Yes, sir.
कंफर्टेबल है ना? मैं फोन ऐसे रखूँ? दिस इज बेटर?
Yes, sir.
ठीक है बच्चे, मुझे बता दे कि जब स्टार्ट करना है।
Sir, we are live.
Okay, okay. So hi, evening friends, evening everybody, bache, evening everybody. I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. And this is the MDS INI recall session for Path and Micro. Sabse pehle, please do keep on commenting in the chat box. Firstly, you had numerous questions from microbiology. There were close to 26 to 30 questions. They were present in all the 4 parts. Part 1 में भी थे, part 2, part 3, part 4. This actually is the first time ever. I mean, if we talk about the past 5 to 6 years, every year we have 3 papers. One is the NEET MDS and the 2 are the INI exams. We have never gotten so many questions of path and micro. I mean, frankly speaking, this was unprecedented. And personally, I think कि examiner को fungal infection हो गया था. I have the exact recall of about 14 to 15 questions with me. The students have told that these were the exact questions which came in the paper. I am still collecting more questions for which, bache, I will be needing your help. So please do keep on writing in the chat box. Do keep on commenting that instead of this, these were the options and so on. And I will again take a recall session with all the changes that you will tell as incorporated. So let us start. Let us start. Which of these infections is seen in HIV? HIV, देखो बच्चे, before I even tell you that the answer is herpes, before I tell you that, HIV we can divide on the basis of CD4 positive T cell count. देखो HIV के ऊपर अपने 2 क्वेश्चन हो गए इसी टेबल से. You will realize that 3 tables in Path Micro will solve your 10 questions. I'll show you those. Another question was, which cell is affected in HIV? Helper T cell, CD4 positive T cell. Now this table tells you that on the basis of CD4 positive T cell count, if it is less than 500, the opportunistic infections are TB, bacterial pneumonia, herpes zoster, candida, salmonella, Kaposi sarcoma, NHL. If it is less than 200, the second column, in that case, the infections associated are pneumocystis jirovecii, herpes simplex virus, diarrhea, HIV wasting syndrome, and so on. Making the answer of our question as which of these infections is seen in HIV? Herpes. You will see EBV will not even come at less than 100 or less than 50. Another important point is less than 50 T cells, CD4 positive T cells, it is associated with cytomegalovirus. It is associated with CMV, cytomegalovirus. Which CMV pneumonia? CMV infection of which site? CMV retinitis. Next question. Next question. Patient with hemophilia comes for extraction of a grossly carious tooth. His factor VIII level is, now I had 2 different recalls. Some told me 25%, that is 25 international units per ml. Some told me 0.25. What is the severity of the disease? Dekho bache, any clotting factor, normal value is 100%. That is 100 international unit per ml. Anything cannot be 100, so it is a range. Normal is 50 to 100. Have a look at this. Normal is 50 to 150. That is normal. Mild deficiency is 5 to 40%. More than 5, but less than 40%. Moderate is 1 to 5%. Severe is less than 1. So in the question, if it was given as 25% or 25 international units per ml, that becomes mild. If it was 0.25, then it becomes severe. Next. Acha, I'll like to say one thing. I'm slightly outside. I was just trying to set up everything. So I do not have the second device with me. I'm not able to see your comments while I'm taking the session, bache. But not to worry. Please keep on commenting. Please keep on telling me any changes, because I'll personally do this session again. I have to put more questions also, for which I will be needing your help. So do keep on commenting. Do keep on telling me the other questions that came. Which of these cells is deficient in AIDS? We just discussed helper T cell. The whole classification of AIDS is on CD4 positive T cell. Simple, straightforward. Sorry. Next question. CRISPR stands for. This is a medical level question. CRISPR, but it is option A. Clustered, regularly interspaced, short palindromic repeats. It is not palindromic region. It is palindromic repeats. The answer is 1, option A. Option A, it is used for gene splicing. So when we have an exclusive micropad discussion, I know it is pretty late today. You guys are also tired watching so many. Say, what is your feel about the paper? Recall and everything is okay. The comments that I am getting from the students is that it was certainly a tough paper. No doubt about it, with undue weightage given to few subjects. I agree. But in the end, you are competing with each other. If you do not know something, the other person also does not know that. So that becomes a non-discriminatory question. Never worry about such questions. Next. Now, the question was vertical branching pseudohyphae. I am pretty sure that this was not the language of the question. What the examiner meant to say was that there will be vertical hyphae along with branching pseudohyphae. The minute pseudohyphae is written, but you do not overthink at all when pseudohyphae is written, Candida. So examiner wanted to tell you that microscopically it shows the presence of vertical hyphae along with pseudohyphae, that is Candida. That is Candida. A very important slide. From this slide, we had 3 questions. So starting with our first image, please have a look. Yeast with pseudohyphae. Sorry. When we talk of yeast with pseudohyphae, we are talking of Candida. They are small yeasts intermingled with pseudohyphae, that is image 1. Image 2, non-pigmented septate hyphae, that is Aspergillus. Aspergillus shows acute angle branching, non-pigmented septate hyphae. Whereas non-pigmented pauciseptate hyphae, pauciseptate means the septa are extremely few, which is associated with mucorales. Mucorales, this was not asked. We had pseudohyphae. And the last question, pigmented yeast with hyphae with septations. You were given exactly this, I guess, that the yeast shows pigmentations, which is associated with demataceous fungi. That is Madurella species, Phoenicia species, and so on. So pigmented yeast with hyphae with septations is demataceous fungi. An important slide even for NEET MDS students. Bache, the purpose of the recall is not only to tell you that this was the question, this was the right answer, but also to prepare you that if such questions are repeated in your future exams, we should be prepared. Next question. We had 4 questions on bodies. And this is something which was exactly from the text, because I was always after your life. Bodies are important. I mean, no double meanings, especially at night. So star-shaped inclusion bodies. Stars are the asteroids which are falling from the sky. Asteroid bodies seen in sarcoidosis. This is what it looks like. You are able to see it is star-shaped inclusion in a giant cell. What is a giant cell? Cell with multiple nuclei is called as a giant cell. So it is an asteroid body seen in sarcoidosis. Next question, HP bodies. One of my favorite question, I guess, in micro. Repeatedly, almost every grand test, I ask HP bodies. Henderson-Peterson bodies, molluscum contagiosum. Molluscum contagiosum. Next, intranuclear eosinophilic inclusions associated with polio and CMV. Cowdry B inclusions. Dekho bache, forget everything. Forget everything. Have a look at this table. For all the students who are juniors who will be giving the next INI or the NEET MDS paper, bache, this table in our class also was repeated twice, thrice. We divide the viral inclusion bodies into intracytoplasmic, inside the cytoplasm, versus intranuclear. First, start with intranuclear. Pink intranuclear inclusions can either be Cowdery type A. Pink है ना, HSV, herpes simplex. It is a sexually transmitted disease. No double meanings. Pink है ना, HSV, yellow fever, and varicella zoster. These are Cowdery type A. Pink Cowdery type B is polio. P for pink, P for polio. Versus blue intranuclear inclusions, which are Cowdery type B, adenovirus, and CMV, cytomegalovirus. So you were asked polio and CMV, Cowdery type B inclusions. Polio is P, P for pink, Cowdery type B, pink inclusion is polio, basophilic is CMV. Simple. From this table, we had 3 questions. One was this. Second was HP bodies, molluscum contagiosum. Third was also asked on pink Cowdery A bodies, that is HSV, herpes simplex virus. So what I am trying to tell you is this table, the viral inclusion table, the table of fungi morphology, and that HIV table of opportunistic infections. These 3 tables constituted your 10 questions from Path Micro. Very important table. So when we talk of tables, they are important. See, pink intranuclear inclusions obtained with a clear halo, obtained by scraping of the base. Pink, that is Cowdery type A, herpes simplex. Simple. I do not have the recall of other options in this, of course, but doesn't matter. Doesn't matter. Pink, P, polio, Cowdery type B, HSV, yellow fever, and varicella zoster, Cowdery type A. Everybody, bache, please give me a thumbs up or like the video if all of you are comfortable with all the points that we have discussed till now. Next question. Deep pink colonies on mucormycin stain. Bache, mucormycin stain, as such, when it is positive, it shows pink colonies. ये तो stain की खासियत है ना, it shows pink colonies when positive, which is cryptococcus. Next. Asha, now you tell me this. Patient with anemia showed increased MCV, but normal MCHC. Mean corpuscular volume is increased. MCV is high. They did not mention maybe MCH is also high. That is why MCHC, mean corpuscular hemoglobin concentration, is normal. If MCV is high, agar volume zyada hai, MCH high hoga. If MCH will be high, then only MCHC will be normal. This shows what? It cannot be iron deficiency, because in iron deficiency anemia, MCHC is low. High MCV with high MCH. Normal MCHC is seen in folic acid and B12 deficiency. Folic acid and B12 deficiency, megaloblastic anemias. And lastly, the most story-like topic, spirochetes, treponemids, organism highlighted with silver stain. We, of course, do dark background microscopy for spirochetes, treponema. Against a dark background, the treponem shows slender white organisms. Because they are very slender, we impregnate them with silver stains also. First class. I am not going to say Lyme's disease last. It is also known as Borrelia burgdorferi, or it is Borrelia's burgdorferi disease associated with spirochetes. I did not have other options. The students were not able to recall the other questions. There were close to 30 questions, bache. We have a recall of about 14 to 16. I know more are needed. There is absolutely no doubt about it. We are not going to settle. We will give you the full exact recall within 2-3 days. No doubt about it, but your help is needed firstly. Secondly, for all the juniors, bache, don't settle, don't stop. We are in this journey together. And I know it has been a long day with all the recalls. I hope from the bottom of my heart that you performed better than you think. And you get a rank, you get a seat better than your expectations. So on this positive note, we end our today's session. Have a well-deserved dinner as well as sleep off. Take care. Good night. Thank you.
So hi guys, we will be starting our session in a bit. Let me just share my screen, and then we'll be starting our kind of session. Okay, so I'm Dr. Pavan, and I'll be discussing the we call as the last part of this. So I'll be kind of discussing with you the questions of your recall session of this particular INI-CET. Just allow me some time. There's some technical glitch on my end. I will be sharing my screen and then we'll be starting in a bit. Okay. Okay. Just allow me 1 minute, please. Okay. I'm audible and visible to you guys. Sorry for all the inconvenience. Just give me a thumbs up if I'm audible and visible to you. Yes, guys? Am I audible and visible to you? Just give me a thumbs up if I'm audible and visible to you. Yeah. I hope I'm audible and visible to you. If I am, just give me a thumbs up. Okay. Right. I think I'm audible and visible properly. Okay, that's great. Okay, so sorry because there was a bit issue with my OBS. I have joined directly through the Zoom. That's why I had to reconfirm. So hi guys, today I'm Dr. Pavan and I'll be discussing with you the recall questions from the general surgery. So there were only 5 questions which are asked, and I would say that the paper was not that easy. Okay, for like a bit tricky questions were there. Not all the questions, but I would say that 2 of the questions or 1 or 2 of the questions were something which was not from the mainstream. So let's kind of discuss these few questions and then we just wrap it up. And thank you so much for sticking around till the end. Yeah. So the first question was the 20 gauge IV cannula delivers the fluid at what rate? So this is something which is expected of you to know. So we need to know what is the different IV cannulas which we use and what is the flow rate from those particular cannulas. Most of the students do know what is the different sizes of IV cannulas, but you forget to kind of, or sometimes you don't remember the flow rate of that. So they had asked you the flow rate. Okay. So the question which they had asked you, 20 gauge, what is the kind of the flow rate. So this 20 gauge is the pink cannula and the flow rate is around 61 ml per minute. Okay. So as per your options, it would be around 50 to 60 ml per minute. Now, different books give different answers. Some give 57, some give 60, that's all. But the answer over here, according to the options, would be B, that is 50 to 60 ml per minute. Okay. That would be the answer. So let's kind of take an opportunity to revise what all things are there over here. So we have the IV, like the cannulas, we have the 14, then 16. 16 is the gray one, 18 is the green one, 20 is the pink one, 22 is the kind of dark blue, 24 is the yellow, and then we have the 26 one. Okay, so what you need to understand is that what is the flow rate? So as I told you, 18 is 90 ml per minute. Okay, 18 is 90 ml per minute, 20 is 60 ml per minute, 22 is 36 ml per minute, and then it kind of reduces down. Higher the gauge, smaller is the diameter. So what is the, what you call as the preferred IV cannula for the patients of trauma? If at all they ask you about the trauma, it is green. Okay, so in the green 18 gauge, it is 90 ml per minute, and the pink, which is the most commonly used IV cannula in our wards, there the flow rate is around 60 ml per minute. Okay, so this is what you can see on your screens. Okay, that was the first question which was asked to you. I would say not that easy. I would rate it as a moderate kind of level question. Okay. Right. Now, this was something which was a new question, I guess. So crystalloids are used in the perioperative period to replace the lost blood. Okay, so they say that, yeah, it is basically used to kind of replace the lost blood. What is the ratio? The ratio in which it's kind of used, it is like 1:1, 2:1, 3:1, 10:1. So the answer I would say is 1:1. Okay, now why I would say the answer is 1:1 is based on this particular paper which I had just come across. So as you can see over here, earlier we used to do the resuscitation in the form of the like 1:3. For example, let's say if at all there is 500 ml of the blood which is lost, we would replace crystalloids in the ratio of 1:3. Okay, so 500 ml of the blood lost, we give 500 ml of the blood and 1.5 liters of the crystalloids. Okay, so that's what you need to understand over here. So fluid resuscitation therapy, therapy by the administration of 1:1 blood replacement ratio revealed adequate compensation capacity of the physiological and the hemostasis similar to that of no lung stiffness in the pulmonary edema. Therefore, considering this ratio, the promotive restrictive fluid administration in the presence of a continuous or occult bleeding. So what you need to understand is, earlier we used to do it in the ratio 1:3, but now as a medical fraternity, we are basically moving away from the transfer of the more crystalloids to the patients. So they conducted a study comparing 1:1 to 1:3, and what you're basically seeing on your screens is the conclusion of that. So the conclusion is that 1:1 is as good as 1:3. So this particular question, the answer would be 1:1. According to me, I guess this is what the question I've received, and based on the kind of the framework of this particular question and everything, the answer I would suggest is 1:1. Okay, so crystalloids are used in the perioperative period to replace the lost blood. What is the ratio in which they are used? It is 1:1. Okay, please try to understand this particular thing. Okay, that's what you need to understand. Okay, now I would take an opportunity to tell you also about the damage control resuscitation. So what is this damage control resuscitation? This is another kind of foot in one way where we are trying to say that, you know what, we are trying to minimize the use of the crystalloids. Damage control resuscitation is something which is followed in the trauma patients. What you basically do in them, you basically do that, you give so what are the four components of the damage control resuscitation? One is you replace the blood products in the ratio of 1:1. That is, red cell concentrate is to FFP is to platelets in the ratio of 1:1. That is the one component of it. The another component of it is something which is called as a permissive hypotension. What do you understand by permissive hypotension? It means that we are trying to say that, you know what, less amount of, if at all, we aim to attain the adequate amount of the blood pressure, let's say 120/80 or something like that. The bleeding will be more from whatever the sites the injury has happened. So that is what is called as a pervasive hypertension. Third is we want to attain the early stoppage of the bleeding. Early stoppage of the bleeding, that is what is the component 3. And the fourth is minimization of the crystalloids. So we as a, what you call as a fraternity, the medical fraternity, are trying to move away from excess crystalloids. And as far as this particular question is concerned, the answer is 1:1. Okay, now let's move on to the next question. This was a simple one. Okay, so A, B, C, D, E of the trauma stands for what? So A basically stands for what? Airway and oral suction. Airway with C spine kind of control. What is the answer? So answer is airway with C spine control. Okay, now guys, whoever is kind of watching me at this point of time, if at all you find that, you know what, there's some discrepancy in one particular question or options or something like that, please put it up in the live chat. And I would also ask you to put something else. Now, this particular answer is pretty simple. It is not the oral section. It is airway with the cervical spine control. Okay, C-spine kind of stabilization. That's what's the answer. Now, I'm sorry, I'm not able to write because I'm not able to connect with my iPad. But what you need to understand over here, if they say small c followed by capital A, capital B, capital C, capital D. So what does this small c stands for? Please try to understand. The small c is going to stand for control of an external hemorrhage. Okay, so for the students who are watching this, who are maybe the candidates for the next kind of year, what you need to understand is that if at all they give small c, okay, so I'm not able to draw, I'm really sorry for that, but if at all, let's say there is small c followed by ABCD, then the small c is going to be control of the external hemorrhage. A is control of airway with the cervical spine. So the most common mistake that the students do is the small c, they consider it as a cervical spine. No, it's not the cervical spine. It is basically control of an external hemorrhage. Okay, so that is what you need to understand over here. Okay, now this was simple. This is according to the ATLS guidelines. According to the ATLS guidelines, this is what is the sequence A, B, C, D, E, and A stands for airway with the cervical spine stabilization. Okay, now moving on to the fourth question which I have is, which of these sutures attract the bacteria and cause kind of wicking of the whatever the soft tissue due to the absorption of the fluids? Okay, so this is again a witty question, I would say, but what they were trying to ask you, they were trying to ask you which of the sutures which are given in front of you is a multifilament suture. That's what the question was. Okay, so frankly, like there's no specific for the silk. What they were trying to ask you was which of these is a multifilament suture. Okay, so this is the answer is silk. Okay, what is the answer? With silk. Now, again, I apologize because I'm not able to kind of write and everything, but just listen to me and you will understand the characteristics of the suture. So let's take an opportunity to kind of understand the different types of the sutures and all those particular stuff. Okay, so what is the first thing which you need to understand in the sutures? That whether the suture is a monofilament suture or a multifilament suture. Okay, now I hope you understand what is a monofilament. Monofilament means that, let's say if there is a single thread, that is what is a monofilament. Multifilament means there are multiple threads. Okay, multiple threads are there, and in order to for the multiple threads to act as a single unit, what we have to do, we either have to twist or we either have to braid on each other. So that is what we have to do. Right now, what you need to understand is, you all would have performed that particular experiment in the physiology where you kind of look for that bleeding time and the clotting time. You take your capillary tubes and everything. What you do, you just put one prick over here. So blood is there. When you kind of put your capillary tube, the blood basically gets sucked up, right? So that is what is called as a capillary action. Yes, everybody understands this? Now, out of these two, monofilament and multifilament, what do you think? Which of these particular sutures is going to have more capillary action? I hope you are answering that it is a multifilament suture, which is going to have more capillary action. So if at all there is a more capillary action, what is going to happen? It is going to absorb more fluid, first of all. Second of all, there is going to be the increased risk of infection with the multifilament suture. Okay, so here the question was, which of the sutures attracts bacteria and causes wicking of the soft tissue? The answer is multifilament suture, which is your silk. Out of all these options, silk is the multifilament suture. Okay, so plain catgut is monofilament. Nylon is obviously a monofilament. Coated Teflon. So Teflon, maybe even if it is a multifilament suture, coated. Okay, for example, if I cut this particular wire, I hope that you understand that there will be multiple small wires inside it, but it has been coated by this particular sheet, right? So that is what is called as a coated. So this is acting as a single unit. Okay, it is no more a multifilament. So if you apply a coat over a suture, it is going to behave like a monofilament suture. Am I making some sense to you guys? Yeah, I hope I'm making some sense to you. So like this, okay, for example, this best example, take up your kind of this. If you cut it, there will be multiple small wires. So in the similar manner, even if there are multiple filaments, but if at all you coat it along like with some particular inert substance, that is what is called as a coated suture. So sticking to this particular question, the question was not really about silk. The question was really about whether you are able to appreciate the qualities of a multifilament and a monofilament suture, yes or no. That was the question all about. Okay, now let's quickly take an opportunity to revise the other things also about the monofilament, multifilament. So we talked about the capillary action and the increased risk of infection with the multifilament suture, right? Yeah. What about the, let's say, handling, like memory? Memory will be more with the monofilament or multifilament. Can you please put it in the comment box where it will be more? So memory will be more in the monofilament suture because the memory is more in the monofilament. What is the memory? Memory means you, okay, after you go out and you work, at the end of the day, you have a memory to go back to your home, right? So that is what is a memory. So let's say if at all we have a thread, and if at all it has a more memory, what is it going to do? It will tend to go back to its original position. So if at all a suture is having more memory, it will be difficult to handle them. First of all, it is going to be difficult to handle them. Second of all, what you need to understand, if at all the suture is having more memory, what does it mean? That when you tie a knot, the security of the knot will not be great. Okay, it will tend to untie itself. It will tend to untie itself. Okay, I hope you are able to understand this point. Okay, so more memory, knot security is less. Okay, more capillary action, more infection. So less, more memory, knot security is poor. That is a part of a monofilament suture. More capillary action, more risk of infection. That is a part of your multifilament suture. Okay, so we have quickly discussed about these few points. Okay, what about the tensile strength? What about the tensile strength? Tensile strength will be more with the multifilament sutures. Okay, so yeah, I can kind of keep on talking about the sutures for next half an hour, but let's not do that. Let's kind of stick to this particular question. Bottom line, this particular question was all about the characteristics of a multifilament suture. I hope you are able to appreciate it. Okay, now this is a question where I want your help. Okay, so consider the options: carcinoma of the kidney, carcinoma lung, carcinoma blah blah blah, XYZ, carcinoma breast. Which of these has maximum chance of tongue metastasis? So what they're basically trying to ask is that which of these has a maximum chance of metastasizing to tongue? Okay, so like the tongue secondaries are most commonly present with what? Okay, so that's what the question was about. Can you please help me with the options, guys? Anybody? Can you please help me? What were the options over here? Can you please help me with that? Anybody? Yeah. Okay. So, okay. As per the question I've received, I don't know what were the correct options or something, but okay. So metastasis to the head and neck malignancies is quite rare. Okay. So it is quite rare. So as you can see over on the screen, metastasis to the head and neck region is from other primary malignancy is very, very rare. But renal cell carcinoma, lung and breast carcinoma are the commonest malignancy. So as per the options which I'm seeing on my screen, I would say 1, 2, and 4. Okay, all the 4 are basically having what you call as the highest chance of tongue metastasis. Okay, so skin, I would not say. Okay, skin doesn't have a high chance of the tongue metastasis. I would say that lung, breast, and whatever the renal cell carcinoma of the skin. Okay, so were the 3 options there? Like, was 1, 2, and 4 in the option? Was there any option which consisted of 1, 2, and 4? 1, 2, and 4? Was there any option which consisted of these 4 things? 1, 2, and 4? If there was, then that would have been the answer. If not, then I would say 1 and 2. Okay, so as per the options I've received, I would mark it as A. But if at all there was one particular option which had 1, 2, and 4, that is kidney, lung, and breast, that would have been the answer. So out of the 3, kidney and lung are the most common. Okay, so I don't know what were the actual options, but yeah, that's what was there. Yes, guys, can I just get a thumbs up? Everybody have understood this particular point? So yeah, the metastasis to head and neck region is quite rare, but if at all it happens, it usually happens no lung and breast carcinoma combo. Okay, no lung and breast carcinoma combo, then I would say that kidney and the lung. Then I would say that the answer is kidney and the lung. So 1 and 2 is the answer. Okay, yeah, in the options, skin was there. Okay, that's fine. Skin is not the answer. So answer is going to be 1 and 2. Carcinoma kidney and the lungs, they have kind of risk of metastasizing to the tongue. Okay, according to me, that would have been the answer, but it will depend a lot on the framing of the question and the options and everything. Okay, right. So guys, that brings us to the end of this particular recall session, this particular marathon, which we all had 19 subjects at one go. And thank you so much for patiently listening. I hope we helped you a bit. Now, what you need to do now. So you're done with your NEET PD, like your NEET MDS. You are done with your INI-SS as well. Now what you need to do is you need to just relax for, let's say, a week or so. Your results will be out, and I'm pretty sure that you guys will get in at one or the other place. But life is kind of brutal, right? So some of you might not get to. That's fine. But you deserve this particular break of 7 to 10 days or something. Just relax, just take in deep breath. Don't think much about the paper. What is done is done. Don't kind of, beat your head around it. What's done is done. And believe me, all of you are in the same boat. So if at all you feel that, your paper is not good, it has to be a relative comparison, but that's not like, I'm not trying to console you or anything like that, but you never know like how good you did or how bad you did. It's all a subjective finding, right? It's all a kind of a subjective kind of what you call as a appreciation of the things or something like that. Somebody would feel that, I've done a really great, but actually they did not do that well or something. So don't kind of beat yourself down. It's okay. Whatever you did your best. I hope you did your best. Now what you need to do is you need to just relax for a couple of days, let the results come in. Whatever the results are there, face it with the utmost kind of courage and everything. If at all you get through, that's great. Congratulations from my end. If not, and if you decide to kind of pursue again, it's okay. It's life. It happens. It's just an exam. It's not, the exam is not going to define your life. Okay. It's just a part of your life. So, but one suggestion which I would give is that before you start afresh, just zoom out yourself and just try to see what you did last year, how you could have done things differently and all those particular stuff. And once you're done with that, then you will be able to kind of take things forward or something like that. But for now, just relax, just kind of zoom out, just switch everything off, and yeah, just have a good time for your 1 week or so. Okay. Hope to see you soon. And just we all at this particular Dr. Bhatia's team, we are waiting to hear back from you guys. As soon as you get the results or whatever, any queries, anything, just reach out to us and we'll be more than happy to kind of assist you with all these particular things. Okay. So thank you so much, guys. Thank you so much for patiently listening to me at this orders at 11:20 p.m. Have a good night. Watch something cool on Netflix or something and just relax. Have a great day. Have a great life. Happy studying. Happy living. Bye. See ya.